Press pause now when you're reading the questions, and then play when you're ready to see the answers. So of course this single best answer is about an ECG. I'd say, as with all investigations, never forget the basics. Never forget the basics. So we've always got to look for first name, second name, date of birth, hospital number, the 4 features of a patient. And that's relevant when you do an OSCE, because those 4 features have got to be on every patient identifying document, such as notes, ECG, X-rays, and so on. So what have we got here? Let's have a look at these in turn. So what best characterises the ECG? Well, question A. So atrial fibrillation, there's no co-ordered atrial depolarisation, so you won't see a P wave. Of course, P waves are representing atrial depolarisation. So, but we can see P waves here, can't we? 1 P wave before each QRS. So we can immediately discount question A. Of course, it's true that atrial fibrillation has many treatment options. The first thing, as with all tachydysrhythmias, is there serious compromise? But anyway, we can move on to B, SVT. Now, supraventricular tachycardia. Well, we can see P waves, it's true. Now, traditionally, we think in most SVTs we don't see P waves, although that's not necessarily true. So we'll hold that thought in our mind. And of course, adenosine, which is a drug that produces temporary but profound AV blockade, is something that's used to convert and or diagnose SVT. So B might be true. C, again, SVT, maybe. We can hold that thought. There's still 1 P wave to 1 QRS, so that's not our number one thing. It's true that in an SVT, the resuscitation council, if you have to shock, recommend a lower voltage than for broad complex or AF. So they would recommend in an SVT 70 joules. So in question C, that could be the right treatment for a profoundly compromised patient who's got an SVT. So B and C are potentials. Let's look at D, sinus tachycardia. Well, I think this is the correct answer because it's got 1 P wave, 1 QRS, and the PR interval is constant and normal, so there's no heart block, and the QRS is narrow, there's no left or right bundle branch block. So I think D is correct because it is sinus tachycardia. And with sinus tachycardia, we don't try and intervene at the heart level, we try and intervene at the systemic level, treat the cause. More of that later. Let's just quickly look at E rather. Sinus tachycardia is not treated by carotid sinus massage. It's one of the treatments potentially for an SVT. So the right answer is D. I've just put here a very broad outline for those that are less familiar with looking at ECGs, as to how to go through it, not forgetting the patient features and clinical information. And this is just a summary here of the main causes or ways of thinking perhaps of sinus tachycardia. There are many common causes. Of course, when we exercise, we get a sinus tachycardia. When we have a fever, when we're in pain, or we're anxious or worried, we may get a sinus tachycardia. Any cause of, we'll loosely call it inflammation, for want of a better, but any infection, any cause of an inflammatory response can cause sinus tachycardia, having had surgery. And of course, any cause of sympathetic activation, so heart failure, hypovolemia, and so on. And there are some rarer, more specific causes perhaps, so we should keep in the back of our minds. But the summary is sinus tachycardia, very common. It's often a sign that something is going on, so it should not be ignored or dismissed. It should prompt a search for the cause, and then of course try and find a solution and a treatment.